being said, when we talk about the brain and we talk about it kind of holistically, there are definitely key components that we have to be aware of. We have our forebrain, right? And forebrain, while it takes the most real estate, is probably one of the more boring components of the nervous system. It has a lot to do with circling. So when we circle, we are going to circle either to the left or the right. And if it's forebrain, it's towards the lesion. If it's vestibular, those are the two locations that cause you to circle. You're going to see the other vestibular signs, and it might be towards or away, depending on if it is peripheral and central or if it is paradoxical. And so the big components of all of that then come into play with now is this cerebellar and is this brainstem. And so we can really deep dive into all of those components. And then, of course, there's the thalamus or the diencephalon. And the thalamus is the one location where basically it takes the rules and says, I don't care. And it's not that it doesn't change, it's just that we don't fully understand it. But you should keep in mind that the diencephalon is a little bit brainstem and a little bit forebrain. And I say that because the diencephalon is technically part of the forebrain, and thus seizures actually can come from the thalamic region in that cranial diencephalon, that cranial portion of what some people consider to be the brainstem. And so it is that region of transition. Where I really wanted to spend a lot of our time is talking about the cranial nerves. What do they mean? And kind of visit back into as many of them as we can, kind of within our hour-long period. Because cerebellar, again, it's like forebrain. It's kind of boring in that it's going to cause hypermetria. And I want to be more specific here with you, a spastic hypermetria. And so it has more of a downward force. So like when you see it versus a high cervical, which may have more of a floating hypermetria. And so there is a subtle difference. And as you kind of move into that like higher level awareness as specialists, just be aware that hypermetria is not just hypermetria. It's that spastic component where they're slamming the limbs down. That is more a cerebellar hypermetria compared to a high cervical lesion that can cause what we call a floating gait. That is technically a hypermetria. It's an overreaching, but it's not spastic. It's very smooth, very pretty, almost like some people would breed for that, like some special types of horse breeds and things like that. So just kind of keep in mind that cerebellar and forebrain, all in all, even though they take up a lot of real estate, is not as exciting as most other regions. The brainstem, however, is where people really come in to say, whoa, what's happening? And so that's where I want to focus a lot of our energy on. And a couple things to keep in mind. Last week, we talked about gait development. Remember that gait is developed inside of the brainstem. And so when we go through and we look at that and we talk about cranial nerve abnormalities, note that with brainstem lesions, you can have cranial nerve abnormalities and limb weakness and ipsilateral proprioception. So just kind of keep those in mind that those can also exist here inside of the brainstem because gait is generated in the red nucleus of the brainstem. And so if we start working our way through the cranial nerves and using that as our map for today, we obviously start out at one, and that's olfaction. Now, olfaction certainly has its place. Olfaction can be tested. However, it is excessively difficult to test it correctly. And so clinically, we don't use this one near as much, but we know that it has an impact, right? Cats that can't smell don't eat as well as cats that do. We typically, clinically, we're going to use the slide test. So for many of you who are looking at nasal tumors and things like that, and you're checking for passage of flow of air, that's going to be the primary one that we still use because, again, testing for olfaction can be technically difficult. And I say that because you can't take an alcohol swab, fill it with, and fill it with alcohol and just wave it in front of the nose. Because what you're actually going to test, and this is the same for smelling salts and alcohol alike, is that it is the chemical component that's going to irritate the mucosa of cranial nerve 5. That's what you're really testing with those. And so if it's not a pleasant smell and you're not going through and using these smelling canisters and hiding them and having ones that have nothing in them versus ones that do, it becomes really technically difficult. Now, in our patients, we certainly have higher degrees of patients who might have different degrees of nasal work. And down here in Auburn, we actually have quite a large working group where they do quite a bit of olfaction study. All that to say, I don't think in the clinical patient that it is worth the time and effort to be like, can you smell? And we can just make an assumption that if the airway is occluded, they don't. And that's about as far as we get in the day-to-day practice component. Of course, working dogs, things like that. There are things that we can do or groups that we can talk with to kind of go to that next level if need be. The star of the show when it comes to cranial nerves is always going to be the eyes. And you can look at it by just seeing the whiteboard that I have pulled up here. Cranial nerve 2, cranial nerve 3, cranial nerve 4, cranial nerve 6. I mean, all of those are literally existing for the eyeball itself. And so that's where we're going to spend the vast majority of our time is talking about these components of the nervous system and the cranial nerves that they talk to us about, because this tends to be the most difficult for people to conceptualize and kind of understand. And so let's start with kind of these middle portions here with the motor nerves. And so we're going to have special sensory systems. That's going to be kind of our retinal cells. We're going to have motor, voluntary motor type cells. And then we're going to have sympathetic systems playing into all of this. And so if we start with the motor, it's very simple in that these motor pathways to the eye are going to be 3, 4, and 6, and they're going to play a role kind of in this. And I always basically remember that 6 does our lateral and 3 does our rectus. And so when I'm going in, I'm trying to be like, wait, where's 3? I literally draw a big 3 no matter where the nose is. So if that's my nose, I'm going to draw a 3 on either side of it backwards. All right. And that'll tell me that, okay, 3 is always closest to the nose, 6 is always lateral outside of it. And so when we look at these, where's the eraser? There it is. Boom, gone. Okay. So when we look at these, 3 is going to be dorsal, 3 is going to be medial, 3 is going to be your ventral, and 3 is going to also be the ventral oblique. So 3 takes care of the bottom no matter what. When we start looking then into 6, oh, yeah, by the way, you guys can move these things. Just be cautious and aware. And so as we start looking at these, 6 is going to be both lateral, but also has an abductant on the backside. So you don't really see it on this view, but 6 has that muscle back behind the eye, that abducens, that allows for retraction in and out. All right. And then 4 is up here at the dorsal oblique. In a cat, super easy to see, right? In a slit-based animal, you can actually see that eye turned out. And I will tell you, clinically, it is super rare to see this. I've only had a couple patients with trochlear nerve type dysfunction, and 2 of them were fungal disease that was just living in their midbrain. So, again, not super common. If you have a dog, you can't really appreciate that externally, but if you look internal and do a good fundic exam, you should see that all of the vasculature is turned and that it doesn't follow that normal peace sign look that you see when you look in the back of the eye. It just looks turned and askew. So you can appreciate cranial nerve 4 deficits, but it requires you to actually look into the eye, which I'm going to be honest with you, if you're dealing with neurological disease, is just as important as any other part of the exam. Doing a fundic exam tells us, is there cranial nerve 4 deficits? Is there optic nerve? Like, why would you do an exam and not literally look in the one location where you can physically see the optic nerve and the extension of the central nervous system? All right. And so again, that's just kind of the quick, hey, here's 3, here's 4, here's 6. 4 and 6, pretty much that's all they do. 3, we'll circle back around to him. He's not done yet. All right. But that's going to be our cranial nerve 4 and our cranial nerve 6. They really only function for dorsal oblique and lateral rectus and then abducens. Those are kind of their main functions. There are some sub functions of 6 that we won't get too much into, but just be aware that those are the primary ones. And those are great, nice, easy, low hanging fruit when you're looking at boards saying, wait, what is the innervation to the medial rectus? Cranial nerve 3, right? Nice, easy, straightforward question. Had another component on, oh, yes. So as we move to optic nerve, we'll talk about that. So any questions on 4 or 6? If not, we're going to pop over to 2, and we'll be with 2 for the vast majority of today. Cool. All right. So cranial nerve 2, obviously the primary guy. Now, fun fact about cranial nerve 2, he's not a nerve. He's a liar. All right. Cranial nerve 2 is an extension of the nervous system. And so it should never really truly be considered a nerve, but it is so much indoctrined into the system of the world that it is just the way that it is. And so we don't worry too much about getting into the weeds of the fact that it's not a real nerve. But remember that cranial nerve 2 is an extension of the central nervous system. And how do we know that? That's because it is lined, the myelin comes from oligodendrocytes, not Schwann cells. And so when we're thinking of the cranial nerve 2, we need to be thinking of it as an extension of the central nervous system. That's why it gets its neuritis. That's why it can have extension when we have raging meningitis. Why is there an extension to the eye? Well, because it's literally and physically an extension of that very similar tissue. And so when we look at cranial nerve 2, where did the drawing go? There it is. So when we look at cranial nerve 2, remember that it's going to get all of its information from the retina. Now, when we look at this left visual field, so we're going to make this big blue L, that's going to be our left visual field. That is going to be the object of our attention. And so both eyes are going to have a component of looking at this L. The medial component makes up the majority of fibers. So in a dog, that's about 75% of all fibers. On the lateral portion, and so this is going to be the portion that's still looking over here to the left, and it's coming down here, that's going to be about 25%. All right. So the lateral component of the globe, that lateral 25%, or what you might hear termed the temporal region, that temporal region is going to have 25% of the innervation to the eye in the dog. In the cat, that number is closer to 65-ish for the mane. And then in humans, we are actually 50-50. So half of our tracts decussate, half of them don't. And we'll talk about that in a little bit when that shows up clinically. But what's important to remember is that both eyes are involved in vision for the left field. And so this plays a role when we start talking about menace, because if you, really do menace correctly, you need to be pretty lateral when you're testing menace if you're testing the visual field. Because technically, menace you could subdivide to medial and lateral fields within the eye. We don't, unless you're a bit of a opto nerd or a neuro nerd. We're not going to. But what that means is if you're really testing it, you need to make sure that you're really over in that, what we call the monocular field, where either one eye is only seeing it, or you're really just at the part that you're really picking up the left side of the world if you're testing this right side. If you come to medial, what you're going to do is you're going to start picking up that other component of it. So when people come in, they're like direct on the menace. I'm like, how about we move a little bit more lateral? How about we get more to that true left field and not be playing this midline game? That's the other reason that we close the eye, right? Is we close the other eye so that we're not activating that other one, and so that we can test each eye individually, because again, it's not 100%. And so if you're covering the eye, that's only half the story. You need to cover the eye and then make sure you're lateral enough to where you're not engaging that medial component, or sorry, that lateral component of the eye, because you're so medial, right? So just some things to think about again as you kind of get your technique a little bit more, that I'd prefer you to be a little bit more on the lateral side rather than this direct, straightforward right on their face. And I think that's something that people just have picked up over the years, but never understood the why. Why do you want to be a little bit more on the lateral aspect with your hand? Because you want to be engaging that medial retina, right? All right. So as we do that, that medial retina, who's in charge, who takes up 75% of the fiber? And you can see that these are human drawings. So really, we should be doing more of that, right? But no one ever thinks about that, because they're like, oh, I'll just steal from the human world. And you're like, okay, cool, but it's wrong. So 75% of these retinal fibers are going to come in, and they're going to travel through the retina. And there's a whole schematic for how that happens, right? There's like layers and layers, about 6 main layers of the retina. It has to go through, come up, activate, go through, and then it gets into the actual retinal cells. And then those are what actually send all of the signal going through. And so as we send that signal down, we're going to collect that all in the optic nerve, located at the optic disc, kind of in that back portion of the eye, and it's going to travel. 75% of the fibers, all of these fibers that are responsible for interpreting the left side of the world. And the reason that this varies, right, is that eye placement is different in the skull for different species. And so what is dictating 75%, 25%, 65% versus or 50-50 is where the eyes are placed because of the species. So just kind of keep in mind that form is following that function. The pathologist would be giddy with that, knowing that we're talking about it. So as we go and we take this retina, we're going to take the majority of fibers. The majority of fibers are going to come down, and they're going to cross from the optic nerve at the level of the optic chiasm. Once we cross the chiasm, that same 75% of fibers responsible for vision of the left field are going to cross and are going to become the optic tract. From here, they do two things. One, they travel to our LGN. So the LGN, all right, or the lateral geniculate nucleus, that is the relay nucleus for vision. Nice, again, low-hanging fruit. Which of the following nuclei is responsible for vision, right? Because if I was writing that question, I'm going to write lateral geniculate, pretectal, parasympathetic cranial nerve 3, cranial nerve 4. I'm going to give you like all of those eye nuclei in there. And the answer for vision is lateral geniculate nucleus, all right? From the lateral geniculate nucleus, then we're going to go up and we're going to go to the occipital cortex of the contralateral side for these 75% of fibers. So the vast majority of fibers here on the medial component of the eye from the retina cross over, go up, and end up contralateral. Now, remember that we still have 25% of that visual field's input coming from our other eye. So now we're going to take that temporal 25% and we're going to take it, and we are not going to cross. So the minority of fibers in these species do not cross. And they do not cross because we need to get all of that information from the left visual field up to our right occipital cortex. And so what you see is these minority fibers do not cross. They stay lateral, which makes sense. They don't want to get in the way of all of those crossings there in the optic chiasm. And so be aware, they're still going to the chiasm. They're just not crossing. They're staying on the periphery, and then they're going to follow up that same optic tract, and they're going to end up on the optic radiation, so that everything that is pulling in this blue visual field is coming over here to the right cortex. Now, the other big component of this is that there is a reflexive component that's not well showed on here that's going to the rostral colliculus. So the rostral colliculus is where visual reflexes are going to go. And now I'm not talking PLRs. That's a whole nother reflex system. I'm talking the when someone turns on a light and you turn their head real quickly, it goes, ah, who's that? That is going to be mediated by the rostral colliculus. So when you just respond to a light or respond to some quiet vision, right? You're like, something's moving, I gotta run. That is all the rostral colliculus. All right. And so it is different than your other PLR systems. The rostral colliculus also, we don't quite understand this fully, but has some degree of function in regulating what our normal eye set should be for a pupil size based on the light coming into the eye. And so it has some secondary components that is involved in understanding how much light is kind of ambiguously around, and then talks with the cranial nerve 3 functions to help us regulate the pupil light into the eye. So then, of course, that's the left side. We have the exact same setup for the right side. So at the end of the day, in our mammalian species, the right occipital cortex is interpreting the left visual field and vice versa. This comes up clinically when we talk about things like what you might hear is referred to as hemi-inattention or hemi-neglect. So this is why some animals who maybe have tumors or dysfunction of their cortex are basically ignoring one side of their world. You might see that they bump into doors or walls on that side that's not interpreting. They may not eat food on that half of the dog bowl. To them, that part of their world does not exist. They can't interpret it. They see it. Don't get this wrong. They see it. They just can't interpret it. And so their brain is like, okay. And so they don't react to it. They no longer fear it. They don't know what to do with it. They just have no interpretation of it. But the eye's working. The brain is not. All right. Before we move on, how do we feel about vision? Any questions? Hearing none. I'm talking slowly just in case someone's typing. We will move over to PLR, which again, similar system. We're just going to keep going. No, so hemi neglect has to do with the cortex. And so kind of went back into that. So the rostral colliculus is more the reflexive components, but hemi neglect is more associated with the cortical dysfunction. Good question. Good clarification. All right. So we're going to start getting now into the PLRs. And you need to know these visual pathways because up to the optic chiasm and partially into the tracts, everything is the same. All right. So here's kind of our line. Everything above that line is going to be the same. Now, it's always funny because we talk about these pre-chiasmal lesions, chiasmal lesions, and post-chiasmal lesions. And the post, it's a little murky. We love for it to be kind of this like nice 3 clean classifications. However, where the post-chiasmal comes off of is a little bit of debate, but it's pretty quick. And so again, it's still a good system. It's just the more you know, the more you're like, well, okay, maybe that's an oversimplification. And it is. Everything in vet med is an oversimplification. But if you keep in mind that pretty much through the optic chiasm, we're going to use those exact same pathways for our PLR, then you can say, okay, cool. I know that if I have a lesion of the optic nerve or the retina or the chiasm, that both my vision and my PLR are expected to be abnormal. They have to be because they use the same anatomical pathways to get that information in. And so We're going to start by talking about our direct pathway. And I'm going to use dark red here. The direct pathway follows the majority of fibers. And hopefully that makes sense when we just talked about the medial retina holding the majority of fibers. 75% of the fibers responsible for vision of the left visual field in the left eye is going to be from the medial retina. And so that's going to be the direct region for our PLR. And so when we say direct eye, that's the eye that we're going to be shining light into. Boom. And so if this is our direct eye, I just told you that we're going to follow the majority of fibers. And so if we remember the majority of fibers are on that medial retina, we're going to say, great, got it. Coming in, going to the optic nerve, look, that's the exact same. We're going to cross. And we cross. So boom, see, I just proved to you that vision and PLR use the exact same pathways up to the optic chiasm. After the chiasm, at some point, right? Remember, that's the part that's a little debatable. After the chiasm, these guys are going rogue. They're like, we out of here, vision, because vision's going to go up. Vision's going up to the occipital cortex. So it's not going deeper into the brainstem. The lateral geniculate, that was its quick check-in, kind of there in that rostral diencephalon region. It's like, cool, hi, I'm going upstairs if you need me. And it walks its little happy butt up to the occipital cortex. The PLR is going down to the basement. All right, it wants to stay low. It wants to stay in the brainstem. And so its little pathway is going to come off here for our direct pathway, and it's going to go to the pretectal nucleus. The pretectal nucleus is located inside of the brainstem, just right there, kind of where the diencephalon ends and the midbrain begins. It's really early on, and it is involved in this pupillary light process. From the pretectal nucleus, we're going to go pretectal to parasympathetic nucleus of cranial nerve 3. Now, if you didn't know this, cranial nerve 3 actually has multiple nuclei. There is the motor nuclei for cranial nerve 3, and then there is the parasympathetic nuclei of cranial nerve 3. The parasympathetic nuclei are what you might hear referred to as the Edinger-Westphal nucleus. This is responsible for actually moving the pupil. And so we're going to go from pretectal to the parasympathetic nucleus of cranial nerve 3, aka Edinger-Westphal. We're going to follow up that cranial nerve 3, where both motor and parasympathetic kind of merge together to follow up the actual cranial nerve. We're going to go to the ciliary ganglion, and we're going to activate that collection of peripheral neurons, and we're going to get then our iris to move, and our iris is going to become more myotic. So we're going to go from big to small. That is the direct pathway. Retina, optic nerve, optic chiasm, little bit of the tract into the pretectal nucleus to the parasympathetic nucleus of cranial nerve 3, follows cranial nerve 3 around to the ciliary ganglion, and then goes in and affects the PLR, and it makes it smaller. Again, that is going to be the majority of fibers. That is why your eye, when you shine the light into the eye, the direct eye, it has a stronger constriction of the pupil compared to your indirect. The indirect, using green, same thing, but we're going to use those temporal retinal cells. We're coming in. We do not cross. We're following now the minority of fibers. The minority of fibers do not cross. And we come in here, we say hello, do not cross the chiasm. They come out, they go the opposite track. They're going to go to their side of the pretectal nucleus. From the pretectal nucleus, there is going to be a single cross. And from that single cross, we're going to follow up cranial nerve 3 then to the ciliary ganglion, and we're going to go. Now, this does cause meiosis, but it's not as strong, all right? And you have to quickly like pop over your image and kind of peek at it and come back, say, yep, that's smaller, it's not, or things like that. So the direct pathway has a double cross at the chiasm and at the pretectal to cranial nerve 3, so chiasm and brainstem. Indirect has only one cross there at the brainstem and then up to the other side. So this is why if I create a lesion here in cranial nerve 2 and I shine a light into that left eye, nothing happens in either eye. But if I have this horrible retinal disease or even a cranial nerve 2 disease in this eye, but this one is functioning, well, if I flip that around and let's say I make that the lesion, all right, so I'm going to flip this around. So right eye is our bad eye. If I shine the light in here, you can see that, of course, the direct is going to work. It doesn't go through that X, but neither does this indirect. So that's how this whole eye could be busted up and not really working at all. You could have horrible retinal detachment or just unilateral optic neuritis or an optic nerve tumor. And this side, going in, you can still get indirect functionality of that PLR on the other side. And so when you have both menace deficits, visual deficits, and you have deficits of PLR, know that that better be bilateral retinal disease. It needs to be optic nerve disease. It needs to be chiasmal disease. But if vision is affected and PLRs are completely normal, that means your function of the retina, the nerves, the chiasm up to the tracts, that is at least all intact because both pathways require all of that anatomy on the front side. It's after we get to the chiasm where we go up for vision, down for reflexes, that we start to see that separation. So that is the 30-cent version of vision and PLRs. Question on vision or PLRs? I'll talk slowly. It's going to move this up a little bit so we can keep talking about menace. Actually, I'm going to use this one for menace. All right. So talking about menace, menace is quite a menace of a response. And of course, that is the most important thing to remember is that menace is a response. It is not a pre-programmed reflex. Menace is something when you learn, you come out as a newborn baby and you're like, the world is so nice and big. And oh, it wants to hurt me a lot. And you start learning that the world is horrible and that even just walking through the woods hurts your eyes. And so within kind of that 7 weeks if you're prey species up to 12 to 16 weeks, if you're carnivorous species, we learn that we have to protect our eyeballs. And so we start programming these automatic processes known as responses. Well, the menace pathway, if you really deep dive into it, is going to have like 18 stops. So there's going to be 18 regions of the brain that play into the menace response, which is wild. It's going to still be a retina. Someone keeps going in and out and it keeps notifying me. So as we go in, the retina in the menace is going to use that same pathway we just talked about. We're going to go to the retina. We're going to go to cranial nerve 2. I don't like that orange color. I guess we're going back to dark purple. All right. So the menace is going to come in and it's going to use that optic nerve 2, right? We talked about that and how it's going to cross over. If we're testing the left eye, we're going to be following the majority of pathways. It's going to come up and then it's going to go over here to the occipital lobe, right? That's the part of the vision that we just talked about. So it's using this entire vision system. So already you can see, okay, retina is 1, optic nerve is 2, chiasm is 3, tract is 4, lateral geniculate is 5, optic radiation is 6, and occipital cortex is 7 in terms of the stops, using quotation marks, along the way, or the different components that it has to pass through. Well, menace has to have some sort of motor component, right? 2 is the sensory. What is the external component? Well, that's going to be cranial nerve 7. So we got to get that motor system down there. But remember, this isn't a reflex. This is a response, which means it requires motor cortex involvement to close that eye. Now, just because it's automatic doesn't mean we can ignore it. And so we have to go from this occipital cortex. Now we're going to send the signal up here to the motor cortex. And now we have to activate the entire motor supply chain. And so we're going to go through, this is going to travel down. It'll go through its different basal ganglia. It's going to get all of those guys involved. It's going to kind of go up. But at the end of the day, it's going to end up in the ipsilateral cerebellum to where we started. Remember, we started in this eye right here. And so we went to the contralateral occipital cortex, we went to the contralateral motor cortex, and now we are in our ipsilateral cerebellum. And it is this who is taking in all of the unconscious proprioception. And this is, we're now getting into why I don't like the term CPs. Saying CPs is technically incorrect because you're basically saying screw you to the cerebellum when you say CPs, because the poor cerebellum is working its butt off to take in all of this unconscious information from our proprioceptive system. And we physically cannot test conscious and unconscious proprioception separately. So when we're testing CPs, again, using quotation marks, we're just testing proprioception. That's it. Not really testing conscious proprioception, because you can't ask that animal what they're experiencing. So you don't know if it's conscious or unconscious. All right, I'll get off my soapbox now. So this is the ipsilateral cerebellum. Remember that the cerebellum is always going to be taking information from the ipsilateral side of the body, and that's where it's getting it from. And it is past that kind of that general region of the brain where all of these tracks cross. So in general, the cerebellum is monitoring the ipsilateral body and is going to receive information from the contralateral cortex. So as this cerebellum comes back, we're then going to go through the motor pathway. And so there's a whole redundancy system of the motor pathway. But at the end of the day, as we go through and we come back, we're going to end up back here on the ipsilateral cranial nerve 7. And so we won't worry too much about how the cerebellum signal gets back here to the brainstem, but no, it does. And it's going to be this ipsilateral cranial nerve 7 that then via cranial nerve 7, we're going to cause a blink response. And so even if you don't want to deep dive into the like 18 or 20, depending on which author you read, steps of the Menace system, what I want you to be aware of is follow that visual system and then activate the motor system. And that's all going to be your contralateral forebrain, your ipsilateral cerebellum, and your ipsilateral cranial nerve 7. Menace is a powerful response system. It's something we can monitor and test really, really easy. However, it is also something that is really, really, really generic. And so there's lots of parts of the brain where we have to be like, ooh, wait, what? Menace is gone. Well, it's not just a forebrain issue. It could be a cerebellar issue. It could be a brainstem issue. And so it's a lot like using proprioception in the body. Proprioception is a very generic, very general test that, yeah, something in the nervous system is off and you have to investigate further, right? We can't just use proprioception to say, yep, here's the exact location of it. All we can say is, yeah, it could be one of these areas. I need more information. Same thing with Menace. I need more information. And so that's where we start looking at other cranial nerves, right? We're going to start going to look at 4. Is 4 and 6, are all of those ocular nerves involved? Because if we start looking at that, if we have cranial nerve 4, cranial nerve 6, cranial nerve 3 all involved, then we're going to ask, well, now, is this a brainstem issue, right? Is our issue down here? And why is, are we really feeling it's brainstem? Or remember, I know it gets so complicated, up in here, right under the base of the skull, there's a structure called the cavernous sinus. So this black arrow is representing the cavernous sinus. There's one on either side of the pituitary. And kind of within that region, you're going to see a bunch of these eye based systems, with the exception of cranial nerve 2. He's kind of got a free all, and some sensory to the front of the face. All of them are going to run through this cavernous sinus. And so, one thing that I think is worthwhile diving into is looking up cavernous sinus syndrome, because you can get a lot of neoplasias that live in that space. Lymphoma loves to go there. And what you can get is compression of all of those nerves, and that can give you some of this internal and external type dysfunction of the eye. And remember that we could say, okay, external dysfunction of the eye, that's going to be cranial nerves 3, 6, 4, versus internal dysfunction of the eye. Well, that's the parasympathetic nucleus of cranial nerve 3. And so, again, I'm going to throw out that term there for you. Go check out cavernous sinus syndrome. One, super cool. And honestly, I think all of you could pick up on it. I genuinely think, because it is so classic. The eye sunking in, it's a little myotic, and it doesn't move when you test oculocephalic reflex, right? So we don't get 8 stimulating and going through and then getting 3, 4, 6 movements of the eye through the oculocephalic reflex, aka the doll's eye. It just sits there and it does nothing. And it's really, really freaking cool to see. So definitely check that one out. Put that on your, hey, let me follow up on that list. And so that's going to be kind of our 3, 4, 6s. Where we've not talked too much is 5. All right. So 5 and 7 are the other two big winners of the facial structure, right? 5 is involved in a lot of facial sensation, right? Touch your nose, touch your eye, all of that starts the blink reflex. There are 2 ways to test it. The first is going to be through the cranial nerve 5 pathway of just touching the face, right? So we often think of palpebral as the primary, and so that's going to be 5 to feel, 7 to blink. Now, technically, you will have different branches for the medial 5 and the lateral 5. So just kind of be aware of that if you want to get into the weeds of it a little bit. But 5 to feel, 7 to blink. All right. And they're all going to end up on the ipsilateral side. So 5 to feel, 7 to blink. And what you have to start doing now is saying, wait, I didn't have any menace, but also I don't have any blink. Well, now I don't think this is a 2 issue. I don't think this is a 5 issue. This is a 7 issue, because it is the most common denominator. And that's really what you're doing when you're doing your cranial nerve assessment. You're saying, okay, I'm testing menace. That is 2 and 7 in its most simplistic form, right? We know how that's a lie. So 2 and 7. And then I'm going to test palpebral. Well, that's 5 and 7. If both of those are absent or diminished, then 7 becomes the key player. Whereas if I have menace, 2 is working, 7 is working, but I don't have palpebral, well, now I'm worried about cranial nerve 5 having sensation deficits. When you have cranial nerve 5 sensation deficits, you might also see things like dry eye and things like that. However, to complicate matters more, cranial nerve 7 does a lot of the lacrimal type innervation and a lot of some salivary gland things along with 9. And you're like, bro, what do you want to be? And so 7 can be a little bit of a pest. But if you don't feel the eye, right, then you're not going to secrete out fluid for that eye. And so both of those can cause lacrimal duct type issues, or more the lacrimal gland type issues. And either one, the lacrimal gland doesn't know to secrete, or it physically can't because 7 is malfunctioned. Now, one other thing on cranial nerve 5 before we do it is nasal sensation. So if I come out here, move my whiteboard down a little bit, and I add in a nose. So here's a nose. Woo, we did it. Yay. It's a horrible nose. I apologize. But if I stimulate this nose over here on the right side, so we're stimulating our right nose, it's going to go up that nose, and eventually what it's going to end up doing is coming in to this cortex over here, the sensory cortex. Well, more up here. I'm sorry. Oops, I got a little wild there. This is the sensory cortex. It's more up there in the prefrontal region. And so 5, when you're doing nasal sensation, it is 5 to feel and cortex to react. Now, I do not care. I do not care if both nostrils are dramatic or both nostrils are quiet, right? That degree of how much they're going to freak out is a cortical decision. And so there is going to be individual variation between each of these species, or each species and each individual. What I do care about is when they're crazy reactive on the left and not on the right. And so you're comparing nostril to nostril. You're not comparing, get out of my nose versus like, I don't care, right? Because like 12-year-old labs, they really don't care, right? Until you like really get up there. Younger dogs, things like that, don't even think about touching it, right? And again, you need to blind them because they're going to be like, you're coming at my face, stay away. So just remember that cranial nerve 5 is not just 5 to brainstem to feel, it's also going to send signal up to the thalamus and up to the somatosensory cortex. And then that somatosensory cortex is going to cause that downward motor function of move my face away from the nose. So nasal sensation is another great way to test the cortex, as well as cranial nerve 5 brainstem for getting that information in and then up to the thalamus. We've already talked about 6, but then we kind of talk about 7. 7, we already talked about him having a degree of facial motor function, right? He's going to be the blink. He's going to be the facial sensation. And so when he stops malfunctioning, we get a drooping of the face. Remember that because our species are what we call extrapyramidal, we talked about this last time, their cortex, their motor movements do not come from the cortex through the pyramids into the body. They're more based on the brainstem. So we don't see that weakness, that drooping of the face with cortextual strokes like we do in humans. But you get brainstem dysfunction or you get cranial nerve 7 proper neuropathies, that's when you're going to see malfunction of cranial nerve 7. And you're going to see that drooping of the face, the drooping of the eyelid, etc. Now, both 5 and 7, they also have some internal players in the inner of the eye that you're only going to see with MRI. And so just know that there are other little things that they play a role in terms of like getting ear fluid out, like tenor pinsae and things like that. The other big component of 7 that shows up clinically is when you touch the inside of the pinna. That inside of the pinna, that is 7 doing the sensory function, not 5. So it is 7 to feel, 7 to move the ear. 7 is completely taken over when it comes to the inside of the ear. And so just kind of keep that in mind, is that your entire face could have no sensory information because 5's malfunctioning, but then 7 works. And so the inside of the ear feels. And so it kind of confuses people from time to time. So just know that 7's a little weird like that. And of course, 5 has its motor component, right? The muscles of mastication. Now, I won't go too far into this because I think of all of the cranial nerve type things, people see this. When you see bilateral disease and unilateral disease, those should mean different things to you when it comes to cranial nerve 5. Cranial nerve 5 unilateral masticatory atrophy is higher associated with tumors. However, don't go around just euthanizing every dog with unilateral masticatory muscle disease, because what they found was that there was a high degree of idiopathic conditions as well, right? And those idiopathic conditions, they came on and then they kind of plateaued. The tumor ones, those kind of progressed. You started seeing more pain and discomfort over time. And just know it's still good to image them because you want to be like, is this tumor, is this idiopathic? But when you have unilateral, that is much more common than unilateral masticatory muscle myositis. Now, unilateral masticatory muscle myositis can occur. It is rare. It is uncommon. And so it's not my first go-to when I have unilateral. When I have bilateral, sure, it absolutely can play a big role in that, right? And you can have things as simple as trigeminal neuritis, right? Dropped jaw, where we just have to give them time, versus cranial nerve 5 motor component, which is going to more show up not as the neuropathy, but as the endpoint of the motor unit. And we talked about the motor unit last time, where it's not just the nerve, right? The nerve, the neuromuscular junction, and the muscle, all of those have to be intact. Well, with masticatory muscle myositis, right, we're attacking those 2 M fibers. Those are only found in the masticatory muscles. And so we're not attacking the nervous system per se, but we are attacking the motor unit. And that motor unit is that kind of that triad of nerve, lower motor neuron nerve, neuromuscular junction, and finally our muscle itself. And so you need all of those to come play into it. And so that's why sometimes that's considered a neuro condition, because it is part of the motor unit. And that is where we get a little bit of the disparity. Wait, who does muscle disease? Is it neuro? Is it medicine? Is it ortho? Right? And at the end of the day, we should all be responsible for it, because it all has different components of it. And so we should all be comfortable with muscle based diseases, in my opinion. And it's only worth about 2 cents, but there's my 2 cents on it. Cranial nerve 8 is massive, 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 and more than what we have time for today. And so, what we'll do is I'm going to send you guys a bunch of cases to work on for the next time we meet. But we'll start with just a quick recap of cranial nerve 8 functionality, just a quick revisit for those of you who may be like, ooh, I don't quite remember this guy. And just a couple tips and tricks as you go, especially if you're getting ready for that phase 1 boards. How do we keep them from tricking you when it comes to the paradoxical, and make sure that you guys understand that process? So we'll start there today, or sorry, start there next time we talk, and then we'll talk about our cases. Cranial nerve 9 and 10, pretty like exciting. 9 and 10 involve a lot of kind of the pharyngeal muscles. When we have dysfunction, we're testing for gag. The other big thing that they don't talk about in a lot of neuro cases is what's called food packing. So if you open up the mouth and you look in the back corner, the side with dysfunction, you will see more saliva, more collection of fluid, because they can't clear it from the back of their throat. And so I find that to be much more helpful than gag a lot of the times. Unfortunately, it doesn't help if it's bilateral, because you're like, well, does this dog just suck at swallowing to begin with? But if it's unilateral, that's where I'm like, ooh, that's money in the bag. All right. Um, and then 11 is a balloon. It has no business being a cranial nerve. All right. That's my opinion, because it is involving all these muscles of the neck. Only one dog did I ever feel like I could appreciate that there was a lesion with cranial nerve 11. But the reason that is it's so redundant. Like, it's not one nerve. It has multiple different branches and nerves. And so it has no business being a cranial nerve. But it's in front of 12. And 12, the hypoglossal, is important. And so it's going to innervate up to the tongue itself, and it's going to do the majority of the extrafusal, so the big meaty muscles of the tongue. Well, when it is dysfunctioned, what's it's going to do is that side of the tongue that innervates it is going to shrivel. And when it shrivels, it atrophies. And when it atrophies, now it's pulling the other side of the tongue over towards the lesion side. And that is why you lick on the side of the lesion, is because it's a biomechanical pull. You are pulling that muscle over as it contracts, and as it atrophies, you're pulling the good side towards the side with the atrophy, with the contraction, and that's why you lick on the side of the lesion. All right, y'all, that was a lot in 1 hour. What questions do you have?